Hi guys, welcome to Psychiatry. Supposedly this is a quote by Freud. I don't know if you actually said it, but I'm gonna pretend like you did. So first topic is conditioning. So starting out with classical conditioning. This is typically what you think of like with Pavlov's dogs and stuff. So it's an innate response that occurs in response to something new. So for example, drooling is an innate response that you expect when a dog sees or smells food, for instance. But drooling in response to a bell, that is something that is learned, and that is classical conditioning. So this is a primitive response that even like quote unquote lower animals will have. So if that helps you remember like classical old, primitive old, you can remember it that way. So the next type is operant conditioning. So this is learning to do a behavior in response to a punishment or reward. So there's like basically four different types. There's positive punishment, negative reward, positive reward. So when you're going through that quadrant that they have in the book, just remember that positive means that something is given, be it a punishment or a reward, and negative means that something is taken away, be it a punishment or a reward. If you remember that, then you can figure out what the different ones mean without having to memorize anything. So then extinction is when a learned behavior goes away if the stimulus goes away. Okay, the next topic was transference. So a transference is when a patient projects something onto the physician other than like the physician's typical role. So the example that you hear a lot is like a patient gets grumpy with their physician because they have like a response to that person as if they were their parent or whatever. And then a countertransference is kind of the opposite, where a physician kind of projects his or her own feelings onto a patient. Um, Nowadays, people just use this loosely to mean whenever a physician has an emotional response to a patient, and it's not necessarily a bad thing. Like sometimes you can have a response to a patient and use that to your benefit to like, oh, I'm like feeling very uncomfortable around this patient. Why? Can kind of give you some insight into a patient's behaviors, for instance. Defense mechanisms. So I'm not going to go through the chart that's in the book. I recommend that you guys watch this video, and if you have time, I would watch it today. You can just click it and open it. This guy explains it these way better than I can, and gives some good examples. So, then moving into childhood disorders. So, starting with ADHD. So, by definition, this has to start by age 12, but can continue into adulthood. Sorry about that out there. And by definition also has to happen in more than two or more settings. So that could be at home, that could be at school, that could be wherever, but it can't just happen in one place. And symptoms include impulsivity, hyperactivity, inattentiveness. And in questions 10, they're going to make it pretty obvious that they're talking about ADHD. And then treatment is stimulants is what you usually think of as first line. So like methylphenidate. Or atomoxetine for people that can't tolerate stimulants. So this is Strattera. Also for younger children, guanfacine or clonidine are often used. These are alpha-2 agonists. The problem with these is that they could have a side effect of hypotension in people in whom that could be a problem. Then sometimes people confuse this as oppositional defiant disorder. So it's not just that a person with ODD is inattentive or impulsive, which they might be, but they're more hostile. They're intentionally defiant toward authority figures. People with ADHD are not defiant for the sake of being defiant. But one thing to keep in mind is that they do not frequently or seriously violate social norms. This could be confused with conduct disorder, in which people do frequently and seriously violate social norms. So they violate the rights of others, they steal things, they vandalize things, they kill animals, etc. That's conduct disorder. And that by definition can only happen until age 18. If it happens after age 18, then it's antisocial personality disorder. Okay, so then moving on to autism spectrum disorders. So you all know the symptoms of this. So social problems, communication deficits, including talking late, not making good eye contact, also having repetitive or ritualized behaviors, lining things up in order, only liking things that are a certain color to eat, etc. Also having restricted interests. Sometimes this can go to the point where the interest becomes like so specialized that the person is a savant. It always presents in early childhood, and it's associated with intellectual disability, Fragile X, and also epilepsy. Seizures are very frequent in people with autism spectrum disorder, and as a general rule, it's more common in boys. So then, Rett syndrome. This is an individual type, quote unquote, type of autism spectrum disorder. Um, it is an X-linked dominant disorder that's caused by MECP2 mutations. And it's mostly seen in females because this mutation is fatal if you don't have one good copy of this gene. And then on a question stem, you're going to pick up on Rett syndrome because they're going to mention regression of skills. So it's going to be a little girl, probably 1 or 2 years old, who initially started talking, but then just stopped talking altogether, and that's Rett syndrome. So other common features are these kids will do this hand-wringing behavior. They'll be ataxic. They might walk late, and they also have intellectual disability. It's very easy to confuse with Angelman syndrome, but children with Angelman syndrome don't necessarily have the autism-like features, and they also have this obsession with water, and they also have this happy puppet demeanor all the time. So that's how you can distinguish it from Rett syndrome. Okay. Then separation anxiety. So this is a specific type of anxiety disorder, and it's characterized by extreme distress when a child is forced to leave his or her parents or home. So this kind of behavior is not normal after age 4. And the way they're going to ask this in a question stem. So for instance, if it's a kid that does not have a separation anxiety, but they're trying to get you to think that they do, it'll be a 3-year-old who gets dropped off at preschool, and they throw a temper tantrum while their mom is still there dropping them off, or their dad is still there dropping them off. But then they go back to normal almost immediately after their parent leaves. That's not separation anxiety. Separation anxiety would be like a 5-year-old kid who makes up some kind of illness or says their tummy hurts so that they don't have to leave their mom to go to school. And the treatment for this is CBT. The problem is, a lot of kids are too young to engage with CBT in a meaningful way, so often you actually end up having to do family therapy or play therapy for these kids. And then Tourette syndrome. So this is characterized by vocal and motor tics. You have to have both for greater than 1 year, and it has to start before age 18, and most of the time it starts much earlier than age 18. The first line treatment is always behavior therapy and education. When kids are aware that they're doing this stuff, they're actually less likely to do it. They can't necessarily suppress the tics very well, because if you try to suppress tics, they come back with more vigor than they would have otherwise. But it at least helps to let kids know that they're doing this. And then pharmacologic treatment includes antipsychotics and then alpha-2 agonists like guanfacine and clonidine, which are especially helpful in kids that also have ADHD, which does tend to happen along with Tourette syndrome. And then tetrabenazine, which you might recall is a drug used to treat Huntington's disease as well, increases dopamine in the presynaptic cleft. And then disruptive mood dysregulation disorder. This is kind of a new thing. Sometimes you'll hear parents say that their kid is bipolar, and what they really mean is that their kid has lots of temper tantrums and that they're really moody and angry all the time. And so this is really what they're talking about, is disruptive mood dysregulation disorder. The treatment is stimulants, and then antipsychotics if severe, and then CBT if the kid is able to engage. Okay, child abuse, and then the bottom line with child abuse is that you have to report all suspected cases of child abuse. There are different forms. So the first one the book mentions is infant deprivation. Basically, babies need a lot of affection. All their needs need to be met by an adult caregiver, and if these things aren't being met, then there can be irreversible damage. So in particular, babies that don't have affection in this critical time period can have issues with trust. They have language issues. They don't function socially correctly. And there's a particularly bad prognosis if this happens for greater than 6 months. And then in the most severe cases, it can lead to reactive attachment disorder. That means that a kid is not able to be comforted even by people that they should be trusting. They can't be consoled by that person. And then physical abuse. So we kind of talked about this last week or the 2 weeks ago with the orthopedic section, but evidence of physical abuse includes fractures, particularly spiral fractures of the long bones, or rib fractures, or multiple fractures and different stages of healing. Bruises that suggest a specific form of abuse. So, for instance, somebody grabbing the rib cage of a child and then they have bruises along their chest, you should be suspicious. Burns. So I've seen in question stems they mention like cigarette shaped burns in the limbs, or like scalding type burns. So like a kid is dipped in hot water. In that case, they're gonna like flex up, and then like wherever the body is flexed together will be spared. But everywhere else will be like have a scald burn or look like they're dipped in water. That's very suspicious. Retinal hemorrhages or subdural hematomas, those are signs that a baby was shaken. Always suspicious for abuse, and then you always have to report, like I said. So in these cases, the most common culprit is the mother. Also, frequently in question stems, it'll mention like a young mom and her young boyfriend. He should also be suspected in these cases. Sexual abuse. So obviously, kids should not get sexually transmitted infections at all. If they have an STI, then you need to think about sexual abuse. UTIs can also be concerning. Obviously, if they have any sort of suggestive traumas, anal, genital, oral trauma, then you need to look into that. In this case, you want to suspect male acquaintances. They're the most likely culprits. Then finally, there's neglect. So that's failure to meet a child's basic needs. That could be housing, clothing, food, water, just general affection or education. Signs of this would be like poor hygiene, failure to thrive, poor social skills, malnutrition. Any of these things need to be reported.